Okay, so hi everybody. My name is Lana, and today I'm just gonna kick off this presentation by introducing the EUMAEUS project. So it's basically a methodological study evaluating the use of methods for adverse events under surveillance relating to COVID-19 vaccine use. So before we go into the details, I would like to first introduce the motivation behind the study. We all know that COVID-19 vaccines are currently being rolled out rapidly across the globe, making it increasingly critical to perform large-scale evaluations of vaccine safety using real-world evidence. Now, the aim of EUMAEUS is to estimate the comparative performance, which includes bias, precision, and timeliness across 4 study designs, namely the case control, cohort, historical rate, and self-controlled methods for vaccine safety. Now, while there have been studies done looking at the comparative performances mentioned here, most were from simulation studies. And that's why the EUMAEUS study is so unique and important because of the richness of real-world data that sits within the Odyssey network, which provides a great platform to evaluate vaccine safety. Next slide, please. Next. So there are many study designs proposed for vaccine safety surveillance, but I would like to bring your attention to 4 of the most commonly used ones that we have used in EUMAEUS. First is the case control study. It's basically a comparison of cases versus non-cases from the same source population from the same time period. Now, advantages include the need for just a small data sample, and you can also easily use matching to control for time-varying confounders. It is, however, prone to confounding by indication, selection bias, as well as misclassification of exposure. Now, this study design has been used in detection of sickness for autism, IBD, GBS, and many others. Next, please. Next, I'm going to talk about the concurrent cohort as well as the historical cohort study designs. For the cohort study, a comparison of incidence rate ratio of adverse events is made between the vaccination and the unvaccinated population. While for the historical cohort, a comparison is made between the observed and expected incidence of adverse events based on historical data. The code is easy to implement, and potential confounders can be controlled by using matching or stratification. The historical comparator has greater statistic power to detect rare adverse events, and it is also known to improve timeliness in detecting potential safety signals. There are, however, some limitations. Cohort studies may be confounded by indication and also susceptible to misclassification of exposure. The historical comparator is susceptible to temporal confounders, such as seasonality, changing trends in the detection of adverse events, as well as variation in any coding or diagnostic criteria over time. Now, in terms of clinical applications, both study designs have been widely used in both adult and pediatric vaccines. Next, please. Last but not least is a self-controlled study design, which includes the self-controlled case series, as well as the self-controlled risk interval. Using this study design, the incident rates in exposed time periods is compared to the incident rates of self-matched unexposed time periods. Now, one of the major advantages of this study design is the ability to adjust for time invariant confounders, while on the flip side, the major disadvantage is the inability to adjust for time varying confounders. It is also prone to reverse causality bias. Now, this study design is also widely used to study signals of various adverse events across a wide range of vaccines, as you can see there. Next, I'll pass on the baton to Marc.
Thank you very much. Next slide, please. So EUMAEUS is an empirical benchmark study that builds upon our prior work where we were looking at the comparative effectiveness and safety methods for drugs that we published in the Harvard Data Science Review. The chief aim of EUMAEUS is to systematically evaluate the statistical performance of methods that will allow us to reliably identify vaccine safety signals. And the key part is in the real world setting, not in the simulation setting. In the real world, we are confronted with a large amount of systematic error, including misclassification and confounding. And little is known about how these different methods function in the real world setting with these types of errors. Next slide. Vaccine safety surveillance methods can be systematically reduced into 4 different components that we're going to explore one by one. These components are first the construction of the counterfactual. So what are the expected counts without vaccination against which we'll compare the observed counts? A time at risk in which one is interested in looking for these observed safety events. Then, given that time at risk and the number of events that happen, one needs to ask, what is the appropriate test statistic that we'll use to estimate a difference between the expected and the observed? And finally, implementing a decision rule based on that test statistic to classify which are true safety signals from the non-signals. Next slide, please. So let me start with counterfactual construction. As Lana mentioned, we're going to look at case-controlled design, the contemporary cohort method, historical rates, and self-controlled case series. In each of these, we're actually going to look at 17 total different variations of these 4 larger designs, each of those drawn from the literature. And to give you an idea of what some of those variants are, if we look at the contemporary non-user comparative cohort method, we might ask, how do we define the non-vaccinated patients or the non-users? Some of the variants in that definition include anchoring or not those non-users on having or not having a healthcare visit within a specified time period, and matching the non-users to the users or not based on different characteristics such as age and sex. In the historical rates comparator, some variants again include anchoring or not and stratifying or not on age and sex. Next slide, please. Let's turn our attention now to both time at risk variations and test statistics that one might use. So the time at risk variations that we're going to explore in the study include 0 to 1 days, so immediately after vaccination, 1 to 28 days, or 1 to 42 days. And most of the results that we'll present today will be looking at just the time at risk, basically within that first month after vaccination. Also within time at risk comes dose definitions. Some of the different vaccines that we're looking at include 2 different injections over a period of time, and we might want to define that time at risk after the first vaccination, after the second vaccination, or using information from both. Finally, in terms of test statistics that we'd like to estimate, obviously there's the effect size, such as the incidence rate ratio, hazard ratio, or odds ratio for the different methods. But we'll also look at test statistics based on the log likelihood ratio. So this is very common in vaccine safety surveillance, and looking at log likelihood ratio variance, allows us, for example, to control for multiple testing over time using an approach called maximum sequential Poisson ratio test approaches. And for each of these test statistics, we'll look at the performance both with and without empirical calibration to help control for the systematic error that exists in real-world evidence. Next slide, please. In terms of the performance metrics, we need a decision rule that's going to help us classify the signals from non-signals. In terms of the effect estimates, those decision rules could be based on bias and variance, particularly the bias and variance estimates that tell us about what is the residual systematic error, and is that reduced under certain designs or not. But in terms of classifying signals versus non-signals, some of those decision rules could be based on type 1 error rates or type 2 error rates. And I'd like to do a quick review of what type 1 and type 2 errors are, because we'll come back to them multiple times throughout this presentation. So a type 1 error is claiming a signal when it is not true. So a very low type 1 error rate means you have a highly specific test. Ideally, one wants to predetermine what that type 1 error rate is, say nominally 5%, but that's very difficult to do when there's systematic error. A type 2 error occurs when you miss a signal that is true. So a very low type 2 error signifies a test with very high sensitivity. Ideally, in this very data-rich realm, we'd like our power to go to 100%, so you might expect the sensitivity, sort of the type 1 error rate, to get ideally as close to 0 as possible. And finally, we'd like to look at timeliness, the amount of time that it takes to achieve a significant power to identify the true signals. Next slide. We're going to do this in the setting of sort of real-world evidence. So our exposures of interest are going to be several different historical vaccination campaigns. The first is looking at exposure to the H1N1 pandemic or flu pandemic vaccination between 2009 and 2010. A couple of different variants looking back at seasonal influenza. And in terms of 2-dose vaccinations, we'll look at the exposures relative for vaccination against zoster and HPV. We'll examine these within 4 different data sets. And across these different data sets, we'll look at our ability to identify signal versus non-signal using 93 real-world negative controls. So these are negative control outcomes that are not related to exposure to any of the vaccines. And they've been specifically chosen so that they have similar prevalence and severity to the adverse interests of special interest for COVID vaccination. We whittled the list down to 93 after extensive clinical review, so that we have signals from these negative controls will also impute positive controls with known effect sizes. This is all done in the setting of open science with pre-specified and registered protocols, open analytic code, and public access to all the results. And on this slide are some of the links to the protocol, the code, and the results as they're unfolding. So next slide. Finally, as we go through these results, there's a couple of questions that I want you to keep in the back of your mind that will help focus the material. First, which of the methods lead to the least bias in real world? And specifically, what's the effect of counterfactual anchoring or not? What is the effect of confounding adjustment? Are these necessary design choices as we move forward? Also, what's the trade-off that we have to make to achieve, say, 50% power in terms of our type 1 error, the trade-off for the type 1 error? A question that came up in our minds is really, should we be combining multiple designs under, say, the signal generation, then evaluation paradigm to improve performance? Is sequential testing correction, for example, adjusting for my type 1 error as we do multiple looks through time, really a panacea for correcting our type 1 error? And finally, does the second dose influence your model choice? Next slide. And with that, I'd like to turn it over to Xintong to begin presenting some of our results on the historical rate comparison methods.
Hello, everyone. So I'd like to go more detail about this method, historical rate comparison. Next, please. So let's record advantages. We have a lesson from Lana about this method, which is including the greater statistical power to detect rare events and also improve the timeliness of estimating the risk. So these 2 advantages make this method especially useful at early stage of vaccination introduction, which is similar to a COVID vaccine in the situation we are in now. And also, I want to remind that the historical rates can be generated from either literature or within the same databases or other sources as well. So here in the study, we are doing the comparison within the same databases, which is also the best case scenario. Next, please. So there's 3 different choices we have in the study design. It's about the population, whether we are unadjusted population or we adjust it for age and sex. And also for the historical comparator, we are either using people at risk for entire year or are related or anchoring on the outpatient visit. And we have a choice of either doing empirical calibration or not. Next, please. So here is a general view about this method. It might not be see the details adequately, but we can see that here the red bar, which represents the type 1 error, is much higher, while the green bar, which represents the type 2 error, is smaller. So this gives us idea that in general, this method is of higher sensitivity, but lower specificity. Next, please. Let's break this down. So here I'm using only one database, which is the CCAE as example. So we see comparing with the unadjusted methods by adjusting to age and sex, we see there's a reduced intertype 1 error. Next, please. And by further anchoring the historical visit, the background rates on the historical visit, we see there's a further reduction in the type 1 error, but we also see there's slightly increased in the type 2 error. Next, please. We also like to see how the empirical calibration works on this. So on the right-hand side plots, the yellow bar represented the uncalibrated one, and the dark bar represented the type 1 and type 2 error for the calibrated results. So we could see that while we see there is the type 1 error has been close to normal because of the empirical calibration, this is actually at the cost of increasing the type 2 error. Next, please. We also see a similar trend of the situation for all other settings and for all the databases as well. Next, please. And finally, let's look at the timeliness. Here I'm using only one database, which is CCAE Westville, and only look at analysis that is adjusted for age and sex without anchoring on historic events and no calibration. So the area under the orange line is the vaccination uptake. So we see for the top row, which is the H1N1 vaccine and the seasonal flu vaccine, the vaccine and uptake is much higher speed and also fast. Higher uptake and also faster speed. We also see that for the top row 2 vaccines, the estimation gained more stabilized at about an early stage, which is about the 3rd to 4th month after the study period. While for the lower row, which is for zoster and HPV, we didn't see the similar cases. So this tells us that this method could generate a stable estimation for the vaccination that was higher and faster uptake and enable an early detection of the potential safety signal. Next, please. So in conclusion, we see that this method, the historical rate comparison methods, is more sensitive but not that specific. It's properly overestimate the risk. And we can also see that by adjusted for age and sex, also anchoring on historic weighted for the background population, we could reduce the positive and lower the type 1 error. We also see that the empirical calibration could reduce the type 1 error, or to say force type 1 error back to normal, but this is at the cost of a huge increase in the type 2 error. And next, please. So I'd like to pass to Faaizah. Thanks.
Thank you, Xintong. Hi, everyone. My name is Faaizah Arshad. I'm an undergraduate student at University of California, Los Angeles, and I'm leading paper 8 of the EUMAEUS initiative. So the purpose of this study is to evaluate whether combining epidemiological methods in vaccine safety surveillance improves signal detection. And I'll be introducing you to the methods, results, and conclusions. Next slide, please. So surveillance systems have commonly employed a strategy called serial testing to improve the sensitivity and specificity of methods. And as mentioned previously, sensitivity is the proportion of people with an outcome of interest that the surveillance system detects as being positive for that outcome. On the other hand, specificity is the proportion of people without an outcome of interest that are detected as being negative for that outcome. And in serial testing, one epidemiological method is performed after another. The first is highly sensitive to identify positive cases, and the second is used to eliminate any false positives. So one example of the use of serial testing in clinical domains is for detecting human immunodeficiency virus prevalence in a population. And usually HIV antibody testing is done in two parts, where the first is a sensitive screening test, and if the screening test is positive, then a second test is done to confirm if HIV antibodies are present. Of particular interest to us was whether applying a sensitive method first and then a specific method improves signal detection. Next slide, please. For this study, we hypothesized that combining methods for COVID-19 vaccine surveillance is desirable, and we tested our hypothesis by choosing two epidemiological designs. The first was a sensitive historical comparator design, and the second was a specific self-controlled case series design. Then we combined them. Next slide, please. Our results showed that using the serial strategy did not actually improve signal detection compared to when the epidemiological designs were used alone. In this plot, we've depicted uncalibrated type 1 error and uncalibrated type 2 error on the x-axis. We have three different designs on the y-axis, and we've used the IBM MarketScan Medicare supplemental database for all outcomes with a time at risk of 1 to 28 days. So I've zoomed in onto the exposure of seasonal influenza vaccination. And when reading this plot, error bars that are closer to 0 indicate higher sensitivity and specificity, while bars that are closer to 1 indicate lower sensitivity and specificity. Let's focus on comparing uncalibrated type 2 error, which are the black bars, for the three designs. We can see that the historical comparator design has lower type 2 error than the self-controlled case series design, indicating fewer false negatives and higher sensitivity. This means that the historical comparator design is less likely to miss a signal when it exists compared to the self-controlled case series design. For type 1 error, the self-controlled case series design has fewer false positives than the historical comparator design, and this indicates that it's more specific and less likely to detect a signal when the signal does not exist. Then when we combine the methods using the serial method, we would expect sensitivity and specificity to be high. But actually, our results show that this is not the case. In fact, the combined method is actually less sensitive than either the historical comparator alone or self-controlled case series alone. Next slide, please. A similar phenomenon is present when we plot calibrated type 1 and 2 errors for all outcomes in the same database and time at risk. Here, the purpose of empirical calibration was to attempt to return type 1 error rates to nominal. And we see that this was successful because type 1 error was closer to 0, notably for the historical comparator design. However, again, the combined method was not highly specific and sensitive in the way that our hypothesis suggested. In fact, again, it was actually the least sensitive. Next slide, please. So from our results, we conclude that combining sensitive and specific designs does not improve signal detection, and therefore we reject our hypothesis. We believe that it's important for future vaccine monitoring to consider the sequence of methods for accurate signal detection. And finally, before I pass it on to the next speaker, I would just like to extend a huge thanks to the entire EUMAEUS team for giving me the opportunity to lead this paper. and especially Marc Suchard and Martijn Schuemie for their constant mentorship and support. Thank you. Next slide.
Patrick, can you pull it up? So the next talk is by Stanford at the University of South Australia. So I couldn't be here in person because it's 1:30 a.m. for him. So we have a recording of his talk.
Hello everyone, I'm Ty Stanford and I've been charged with telling you about what we found when we used the second dose information in the EUMAEUS study. A special thanks goes to Associate Professor Nicole Pratt and the human genius that is known as Martijn Schuemie, as well as the rest of the EUMAEUS task force. Starting with the aim of our sub-study, we're primarily interested in our ability to find exposure outcome signals, and does adding second dose information help our cause? Put more specifically for EUMAEUS, this is finding vaccine and positive control associations, and we quantify this using type 2 error as the proportion of vaccine and positive control pairs we have missed. Ideally, we want this to be 0. Having said all of that, we would not ignore type 1 error, which are non-signals classified as signals. Here we'll focus on Optum EHR database in this talk for simplicity in the figures presented, and we will look at the 2 largest double dose vaccines in EUMAEUS. Let's quickly start with some descriptive statistics to know the sample sizes we're working with. Here are the underlying dose uptake rates, and noting the second doses only count for about 10% of the HPV and 30% of the zoster first doses. Keep this in mind when we see the results. Okay, please stay with me as I talk through these somewhat busy graphs. But first I should point out, here we're just trying to get a feel for the type 1 and type 2 errors for the 4 study designs based on only the first dose before looking at the second dose. Looking at the uncalibrated set of panels on the left, we once again have the unrelenting march of time on the x-axis. On the y-axis is the error between 0 and 1. The panel rows are the case control, cohort, historical comparator, and self-controlled case series study designs. Within each panel, there are 4 lines representing the type 1 error and the type 2 errors for the 3 different underlying true effects of 1.5, 2, and 4. The type 2 error lines go from dotted to solid lines once they reach 50% power, and the orange type 1 error line is complemented with a lighter band representing the 0.05 nominal error plus or minus 0.02 for illustration. In an ideal world, we would want the type error near nominal at 0.05 and the type 2 error as close to 0 as soon as possible. When looking at the results without empirical calibration on the left, we see only the cohort method seems to control the type 1 error, but that comes at the cost of higher type 2 error. The self-controlled case series design had the lowest type 2 error before calibration. However, the type 1 error is problematic. Empirically calibrated results on the right shows calibration does an excellent job of controlling the type 1 error, but of course, in most cases, this comes at the cost of type 2 error. So let's look at the second dose for the best study designs in regards to type 1 and type 2 error. So let's start with the type 1 error champion of the world, to add some hyperbole, the cohort design. These plots will be familiar, except now the panel rows are for comparing the single dose data to the both dose data. Now we're a little bit more zoomed in, the type 1 error can actually be seen to be below nominal when uncalibrated, and corrected with empirical calibration with a slight reduction in type 2 error as a result. Adding the second dose data to the analysis reduces the type 2 error somewhat, but is likely to be muted because of the lack of second dose accumulation. Now we turn our attention to the self-controlled case series design, the type 2 error champion of the world. Prior to empirical calibration, the type 1 error was a real concern, but after the calibration, the type 1 error is nominal with quite good type 2 error results. Where the true effect is large, i.e. 4, there's near zero type 2 error at 12 months in all situations shown. However, the reduction in type 2 error when adding the second dose are modest when looking at the type 2 error curves for true effects of 1.5 and 2. We now reach our conclusions. The inclusion of the second dose can increase the power. However, this is just seen as a marginal increase, probably as a result of the marginal increase in sample size. The most important factor we observed is empirical calibration. More data doesn't magically negate issues with specific designs. Future work to better understand the issues would involve a larger proportion of first doses to also have second doses, and also if we look at the uptake at different rates. Another way to look at it would also be changing the underlying signals, so the positive controls, to have varying effects for each dose. I've left this off the list shown, but I would observe that while more data doesn't perform magic, I might unofficially claim empirical calibration does. It is some kind of wizardry. Another last note I would like to make is an investigation into positive predicted value and negative predicted value might be important clinical perspective now we have characterized the type 1 and type 2 errors. Thank you for the opportunity to talk today or tonight or whatever time it is in your part of the world.
All right, awesome. I'm gonna now take over, hopefully. All right, can people see my slides again? Nope. I'm not seeing anybody. All right, good. All right, so up to me for the to give the last part of this presentation. I'm going to be talking about comparing performance across methods, although I guess some of the previous talks have also done that. For my talk, I've just picked one representative of each major method just for simplicity. So one case control, one cohort method, etc. And I thought I'd start by just showing you an actual estimate that each of these methods produces for a negative control. So here, for the estimate for contusion of the outcome of contusion of toe for people vaccinated for H1N1 in the Optum EHR database. And so what you see is that these four methods actually produce very different estimates for exactly the same research question using exactly the same data. So the choice of method has a great impact on what a surveillance system, a safety surveillance system would find. But of course, this is just one negative control. We did this over a lot of negative controls, and you've already now seen these type of plots a few times where we actually summarize the performance of a method into type 1 and type 2 error. And so, for example, what we see is that the case control and the historical comparator methods tend to generate many false positives, leading to high type 1 error. And other methods such as the self-controlled case series, for example, do not. But we do see that the historical comparator has very low type 2 error. So is it then better or not than, say, the SCCS that has higher type 2 error, but almost no type 1 error? So it's very hard to compare methods if we allow both type 1 and type 2 to vary. So what we've done, as already showed a couple of times in the previous parts of the talks, we've applied empirical calibration where we use the estimates from the negative controls to basically get a good sense of the bias of a method, and we calibrate the estimates that come out of it to restore type 1 error, usually at the cost of type 2 error, although not actually all that much in this particular instance. So now that we've done the calibration, it's easier to compare methods. And actually, in this case, we see that now that type 1 error is more or less the same for all methods, the SCCS method actually seems to be the winner here in that it has the lowest type 2 error across all positive controls for the same type 1 error, if you will, as the other methods. But this systematic error that we're adjusting for is not the only problem that you should be adjusting for. As anybody who's familiar with vaccine safety surveillance can tell you, another important aspect is sequential testing. So if we're using the same data month after month to look at the data to hopefully detect safety signals as early as possible, we have to take into account that we're doing multiple testing on the same hypothesis. And as Marc already pointed out, there is this procedure called max SPRT that we can apply to correct for that sequential testing. So just as an example, I'm showing you the historical comparator and the SCCS methods and their type 1 error after various types of adjustment. So at the top, just focusing on the historical comparator, if we don't calibrate and we don't adjust for sequential testing, we have a type 1 error rate of 28%, which is pretty high. But of course, we need to do sequential adjustment for sequential testing. So if we do that, the type 1 error drops significantly or a lot to 18%. But actually, if we do the calibration and not the adjustment for sequential testing, we drop even further to 10.8% type 1 error, which is still not the nominal 5% we're looking for. Of course, what we really should be doing is we should be doing both. We should be calibrating for systematic error, and we should be using max SPRT for adjusting for sequential testing. And so this is actually a new methodological development that we've done in EUMAEUS, and we're actually now able to do calibration in the context of max SPRT. And that for a historical comparator gets us to a type 1 error of 6.5%, which is close to nominal. So we're happy with that. It's certainly a lot better than what we started out with. SCCS, we see that it actually already wasn't very biased to begin with. Type 1 error was already below 5%, and we ended up with that at the end, close to that. Or actually exactly the same value at the end. So if there's no bias, there's also no correction, which we would like. So now that if we're applying both adjusting for systematic error and adjusting for sequential testing, now we've put all the methods on equal footing, I would say. And now the real question is, well, if we apply them this way and they have similar type 1 error, which one actually gets us the answers quickest? So who can find the positive controls the fastest? So what I'm showing you here is on the x-axis is the time in month to reach 50% sensitivity. So finding 50% of the positive controls. I chose 50% because we never actually get to 100%, which is something to look at, which is we need to find a solution for that, obviously. But and I've divided it into the true effect sizes. And so you see at the top that, for example, the matched case control after calibration and adjusting for sequential testing actually never reaches 50% sensitivity for any of the effect sizes. Whereas at the bottom, the SCCS, because there was actually not that much adjustment needed, it actually is capable to find, well, true effect sizes of incidence rate ratio of 4. It's able to find it already after 1 month. So that's very quick. If the effect size is 2, then it actually takes 6 months. And then, but actually, if the true effect size is 1.5, it never reaches 50% sensitivity. So when all are equal, at least in terms of type 1 error, we find that SCCS actually has the shortest time to detection. But all methods struggle to achieve 50% sensitivity for small effects. So we didn't just do this, of course, for these 4 examples and just in H1N1. We did this across all method variants and across all vaccines that we looked at. And we did this all across all databases. But of course, I'm not going to go into all of these details. But basically, the conclusions are pretty consistent across all the variations that we looked at. So in conclusion, many of the methods that we looked at show large systematic error / type 1 error. Applying empirical calibration, which we've been using in Odyssey for quite a while now, can restore type 1 error to nominal at the cost of increasing type 2 error, although how much of a cost depends on how much systematic error there was to begin with. Empirical calibration actually often has a bigger impact on getting type 1 closer to nominal than adjusting for sequential testing, which is not to say that we only should do empirical calibration, but I'm actually suggesting we should do both because they're both important. After we calibrate and adjust for sequential testing, the SCCS seems to be best overall in terms of the shortest time to detection. However, no method achieves high sensitivity for small true effect sizes, which is an interesting finding that we need to see how we're going to deal with that. So now I'd like to wrap up our set of talks by just going over some recommendations that we would have for if one were to build a safety surveillance system. So because many methods have a positive bias that cause many false positives, high type 1 error, we recommend that any system should include negative controls and use empirical calibration, but at least use negative controls so that you're aware that you have a high type 1 error rate. You should probably include self-controlled designs because those tend to show a low type 1 error. You should always use confounding adjustment, which sort of seems to go without saying, but especially when we're trying to quickly monitor, that is something that sometimes is not done. And when you're doing anchoring, you should carefully consider what anchor you use for your counterfactual. Detecting more than half of true adverse effects may require accepting more false positives. So we saw that at an alpha of 0.05, so cutting off at a p-value smaller than 0.05. We didn't get to a 50% sensitivity when the true effect size of was 1.5. So we may actually need to increase that threshold, accepting more type 1 error, but getting more sensitivity in return. As Faaizah showed, combining multiple designs actually didn't improve performance, at least not in the examples that we looked at. And so we would argue that currently there is no evidence that suggests that it makes sense to distinguish between signal generation and signal evaluation, especially when it's possible to run all of these methods at a large scale. So using them for signal generation, it's not sure whether then it should be a next more advanced technique to use. The second dose is often underpowered to contribute to evidence, but that of course may not generalize to the COVID world, where we luckily see a much higher uptake of the second dose of the COVID vaccines. And that's the end of my talk. So thanks everybody. Thanks to all the speakers for their wonderful talks. And let's open the floor to questions.
Hi guys, it's Christian. Martijn et al., how did you measure the errors? Are these positive? Are they spiked in? Or how do you know what's an error and what's not?
So we used negative controls and simulated positive controls. So the negative controls were real. So these were like the contusion of toe. Like we really believe that that's not caused by any of the vaccines. So that's a real negative control where you saw that some of these methods actually found very large effect sizes for this real negative control. And in the positive controls, we use a new technique that we call imputation, where it's actually pretty simple. For a method, if it produces a certain estimate for a negative control, we just multiply that estimate by the true effect size to make it a positive one. And that's just to get some sense of what the type 2 error would be. So that has some assumptions behind it, this approach. But basically, type 2 is based on simulation. Type 1 is based on real negative controls.
I think that's a very important point. Like if you had to rest your hat on our type 1 or our type 2 error estimates, I'd say our type 1 error estimates are accurate because they're based on really, true negative controls. Our type 2 error rates are more approximate.
And are they gonna, the critique that's gonna come, are they gonna come down on basing the type 1 on negative controls, saying, well, the type 1 error could be very different for positive controls and could behave differently? Are you going to see that coming?
So we haven't seen that argument previously in our work using negative and synthetic positive controls. It could arise. The challenge is real positive controls don't exist in a practical setting. You know, if something's a positive control, there's strong prior belief that yes, it's a non-zero effect, but we don't know what the true effect size is. So yes, it's not zero, but is it 0.1? Is it 0.378? And then if something is strongly believed to be non-zero, that immediately changes clinical care. And that changing of clinical care changes, you know, both the exposure that might be influenced to that positive control, and then our measurement of the outcome itself. So, real positive controls are a conundrum unto themselves.
Faaizah, you have a question? You raise your hand.
Yeah, I was wondering, were these main findings consistent across all the data sources and across all the vaccine types? And basically, was there any differences in the EHR versus the claims?
Yeah, so by and large, I would say that they are consistent, although there are, of course, differences in that. We saw that for H1N1, we never reached 50% sensitivity, but if we look at all flu vaccines in a particular year, we actually do get there, but that's because the numbers are so great. And I do believe that, for example, the EHR database that we use actually showed more type 1 error for some reason than the claims databases that we used. So there's consistency, but there are also differences between the various databases that we looked at and vaccines.
Just one follow-up point. So if the vaccine, if the influenza, we believe that it was the size was not an issue because of how much data we have. Do we think that COVID might not have a big problem with sensitivity, basically detecting small effect because we have a lot? It's a nationwide, everywhere exposure.
Yeah, so I should somewhere pull up the numbers that we. So even like the H1N1 had like hundreds of thousands of vaccinated patients. So of course, for COVID vaccines, we have more vaccinations than that, but we need to have data on that. But so your point is well taken. We need large data, and then we don't have to worry about this problem. But that does mean really large data.
And that also
As a
takes
follow-up.
into.
I'm sorry. Go ahead, Marc.
Well, I was just going to mention, you know, although the similarities in the proportion of the population vaccinated is going to be similar between COVID and seasonal influenza, the data availability is different. I mean, here we used a historical availability, although we did section it by, you know, by month as individuals are vaccinated. But for seasonal influenza, everyone's vaccinated. Well, most everyone is vaccinated within about a 2-month window. For COVID, it's going to be much more rolling, right? We have big uptake, and then it's going to be very slow. So the work on timeliness is very important. And to hark back to Ty's comments, you know, the self-controlled methods seem to be the best performing in that avenue. Sorry, Patrick, you had a follow-on question.
Well, I was just going to highlight to follow up on that. Case asked a question in the chat about these results are in the U.S. data sets. Any comments that folks would make about whether we would expect similar findings in European data?
So yeah, unfortunately, we didn't use any European data just because the way that we set up the experiment, like these vaccines, actually, we couldn't detect them with high enough frequency in some of the European databases that we looked at. Like the zoster vaccine is not really used in most of Europe. I honestly have no clue how it would perform in Europe, because I think the data capturing mechanisms in Europe are quite different from the ones in the US. But yes, we'd need to try, but then we need to change the design of the EUMAEUS experiment to also basically run on in the European setting.
There are a couple of comments from Donnie in the chat expressing interest in moving forward and replicating as possible EUMAEUS and CPRD and one other data source that's fallen off the line. So we'll have to look into what modifications are needed for different exposure for identifying equivalent exposures across the data sources.
So we're at the top of the hour. I first just want to thank Lana, Marc, Xintong, Faaizah, Tai, Martijn for a really extraordinary presentation. I know you guys put a huge amount of work in to prepare this, and it really showed in terms of the polish and professionalism. And I think these results are going to have major impact on public health. So excited to see you continue to move this forward. For those of you who are interested in engaging in learning more about EUMAEUS, there are weekly calls at 8 a.m. Eastern time on Fridays. And it's as part of the PLP working group for those who are not yet signed on. And otherwise, I think you can expect to see a lot of important contributions coming out from the EUMAEUS group through publications and subsequent presentations in various forms. So thank you, everybody, and look forward to seeing you all next week.
Thanks, everyone.